Thank you, Mr. Chairman, and I'd like to thank the organizers for inviting me here today. Actually, I'd like to share a single case that we've done quite recently in Malaysia. So this is a case of quite an elderly gentleman. And before I start, I have no disclosures except that I've accepted proctor positions for Abbott as well as LifeTech. But in terms of ASD pulmonary hypertension, these are a troubling group of patients. We've often tried to deal with them, and also, in the past, what can we offer this group of patients? What can we do to make their lives better? Is there anything that we can do for them? In the past, what was initially taught to me when I was a fellow, if it's more than 8 wood units, nothing can be done for them. And if it's between 5 and 8, it's dicey. But are these principles true? Can they be challenged? Can we improve upon them? Actually, there are new paradigm shifts. So when we thought about them, and as well as some of the surgeons thought about them, some have developed innovative ideas and designs to try and deal with these things. So what the surgeons have done in the past is try to fenestrate the ASD patch. Others tried PA bending, and while some are even more innovative, like Professor Dr. Shingo Kasahara, my good friend, he used to tell me that he used a partial lung transplant from a parent donor and then closed the primary defect as well. And they've got good results on those cases. So actually, can we actually replicate this? In the past we did. We fenestrated our ASD devices, but despite our best efforts, there's a tendency for these fenestrations that we create to close within a few weeks to 3 months, and then the patients are left to struggle without any good results unless we went in again and tried to stent the fenestration. More recently, the companies like Sarah and Occlutech have listened to us and decided to fenestrate the device for us, making our life easier. So in terms of Occlutech, they've got the atrial flow limiter, and Sarah, the fenestrated ASD device. So I'd just like to share one case that we did. This is an elderly gentleman, like I mentioned previously, 56-year-old man, noted to have a very large heart and pulmonary trunk on chest X-ray, and he came in to our attention because he had shortness of breath and cyanosis as well. And then when we did the echo, there was quite a large ASD with marked right-sided dilation, with mild mitral regurgitation secondary to rheumatic heart disease, and the tricuspid regurgitation was said to be 84 millimeters of mercury. And we attempted to do something for him. So these are his echoes. So you can see that they're actually quite large, the defects. And he's got this RARV dilation. So we actually went to CAF him as well. This is his CAF data. If you look at the CAF data, we've estimated his pulmonary vascular resistance at 28 wood units. And then his MPA pressures were basically just subsystemic. So we went on to decide to close his ASD, but with the new fenestrated Sarah device. So the device comes fenestrated, as can be seen here. There is a hole that the engineers make for us, and then what they have done is they have melded in such a way that the memory is such that it will keep this fenestration. And there's no disruption to the metal wires like what we did, and also there's no Teflon or material sticking in the hole. And they've calculated based on the size of the device that we want to use. And for this type of cases, I always balloon size them, because you cannot oversize them too much, otherwise the fenestration will be compressed as well. And in the past, we frequently put the device with the fenestration, a wire through that, and we then deliver the device and balloon again if necessary. But in this case, I thought it was unnecessary. So we sized the patient like this, and we went on to deliver the device. And since we've got the balloon there, we did a balloon assisted, and then we went on to release the device after the tug test. So you can see we gently tugged the device, it stayed stable, and we went on to do the echo before release. So this was actually the echo before the release of the device, and what we could see was there was flow through the fenestration. And then subsequently we released the device. And this is at 1 month of period after we have released the device. So there is some improvement at 1 month, and if you can just make this out here, the fenestration is in this region and it's still patent. So at 3 months, what I'm going to do is let you see the differences. So this was done before the procedure, this echo, and this is at 3 months. So what we can see is that even there is some septal reversal now. Okay. And again, before, with very marked RV dilation. And at 3 months, we can still see some bidirectional flow through that. But the TR has decreased, the RV has decreased, and so has the RA. So we are very hopeful in these cases. And the initial 3-month follow-up results look promising. And the patient is supposed to be on sildenafil, but we're not sure if he's taking it or not. And the fenestration appears patent even after 3 months. And it's very encouraging in that we achieve RV reduction. And in fact, his 6-minute walk test that we've performed on him has improved from over this last 3 months. So this is the first case that we did in a northern hospital in Malaysia. And I'd like to thank all those who made this possible together with myself. So Dr. Cheng, Dr. Lee, Satwinder, and Dr. Saravanan. And for the patient himself, because he agreed to this procedure, even though we told him we are in somewhat uncharted territories, and it may aid him, but we're not completely sure it would. And with that, thank you. CSIAP.
Dr. Wong, for this beautiful presentation. Is there any question or comment? Nobody? No question?
Thank you for your excellent result. Do you recommend to repeat the angiography for better estimation of the PA pressure after the ASD fenestrated closure?
Yes, we were hoping to do that later, but what we've done is we intend to follow him for the next 6 months, keep him on the pulmonary vasodilators, and at the end of 6 months, we'll do a catheterization, measure the pressures again, and decide what to do from there on after that. I mean, if his pulmonary vascular resistance does come down significantly, then we'll be very happy, but I would still probably leave that fenestration alone and not try to close it at this time.
In some cases, the PA measurement by the echocardiography in the follow-up outpatient clinic showed the low PA pressure. But after the measurement of the PA pressure in the cath lab showed the higher pressure compared to the echocardiography. It's very important for how many times we can continue the drug of the patient and cancel the drug management.
Yes.
I also have a question for you. Did you estimate QP to QS before you closed the hole? Because, I mean, 28 wood units is really high.
Yes.
So did you calculate QP to QS?
We did, unfortunately, but I can't remember, and I didn't reproduce it for this slide. It was still more than 1.5 to 1. That's why we proceeded. 1.5 to 1, about that. I don't exactly recall the values.
Okay, sorry. One more question, please. When you measure the pressure in the pulmonary artery and you put the balloon inside, do you measure at the same time with another access with catheter? Means
No.
balloon occlusion measure the pressure.
Sorry, I didn't do that. We ballooned to assess the size. Like I said, we didn't oversize a lot. We measured it at 34, 35, and I put a 36 device.
Thank you.
My comment is about the measurement of the QP to QS. In this patient, we have a right to left shunt, and O2 saturation in the aortic side is very low. Your patient showed the O2 saturation, aortic O2 saturation near 80%. Measurement of the QP to QS in this patient is very difficult because we have a bidirectional shunt, and I think is not necessary for this procedure. You think it's necessary for this procedure?
Well, so you want to answer?
I still routinely measure it though, because it gives me some comfort that there's still some element of the QP is larger than the QS before we go on to close it. I guess you would agree.
I absolutely agree. I accept your point, but still, we would, in these cases, at least do also a testing with NO and oxygen, and we would do everything, and then make a real long thought. With 28 wood units, we probably would not close the hole, actually. But I mean, you're successful.